Hello, I'm Dr. Mallory Shields, a Senior Clinical Sciences Manager at Intuitive Surgical. Along with my co-first author, Dr. Busi Malambo, and our global team of collaborators, we're excited to share a recent publication entitled A Standardized Temporal Segmentation Framework and Annotation Resource Library in Robotic Surgery in Mayo Clinic Proceedings Digital Health. This work addresses a critical challenge that's been acknowledged as a barrier in the field for years, holding back surgical innovation: the lack of an accessible, standardized, universal language to segment surgery over time. We've developed a comprehensive hierarchical framework that enables the consistent breakdown of any robotic operation into standardized, measurable temporal components with defined start and stop parameters. Our paper outlines this framework with 4 nested levels of granularity. At the top, or the least granular level, we have 5 fundamental phases that apply to virtually all procedure types, regardless of specialty or procedure type: exposure, dissection, transection, reconstruction, and extraction. Whether it's a gallbladder removal or a hysterectomy, every operation uses some combination of these phases. Within each phase, we define steps, major surgical milestones with clear objectives. Steps contain tasks, which are necessary components needed to complete that step. Lastly, subtasks can capture the technical variations surgeons use to accomplish that task, or that together make up that task. This nesting enables all annotations to be tailored to the granularity of specific project needs, research questions, and AI developments while maintaining consistent start and stop parameters. What makes this flexible and scalable and ultimately impactful for the field is that we've applied this hierarchical framework in real clinical cases across procedure types to create the first annotation resource card library, essentially surgical playbooks, for 10 high-volume robotic procedure types. As an example, here's a portion for the annotation guide for robotic-assisted cholecystectomy. Each of these procedure-specific resource guides breaks down each segment of the procedure across all granularity levels with 3 standard components. The first component is the identification of the overall surgical objective of that segment, regardless of if that segment is a phase, step, task, or subtask. Second, each segment is functionally named with the inclusion of a specific surgical intention, using at least one action, which is represented by a verb, so that the name explicitly describes what will be completed by the end of that segment. For example, triangle of Callot is not an acceptable segment name, but dissection of the triangle of Callot is. The third component is critical. Computer-readable start and stop parameters are defined for each segment, always with a specific interaction between a surgical tool type and its target, like patient anatomy or surgical material. It's that interaction which initiates or completes the defined surgical objective of that particular segment. With these standard components, when a specific instrument touches a specific target, models can be trained to recognize that moment, triggering the start or stop of a segment. This transforms surgery from subjective description into objective, analyzable, and scalable data. This framework has been validated using over 13,000 cases, with 7 years of iterations and collaborations across the globe, and with a quality control assessment performed quarterly by a team of professional annotators. For the clinical and surgical data science communities, these resources can help overcome many of the challenges the field faces today. If this framework is utilized globally, clinical and surgical data science communities can utilize consistent language in clinical settings for best practice and standardization throughout surgical training. It can objectively and reliably track surgeons' skill progression over time using performance metrics calculated within these standardized surgical segments, like durations, speeds, workspace volumes, and forces. In this way, surgeons can objectively identify which components of surgeries need practice and can track their progress systematically. Leveraging these turnkey guides for consistently and transparently segmented data will enable scaled algorithm development and catalyze AI tool development, which can ultimately help accelerate surgical innovation to make surgery safer and more effective for patients. This publication represents a foundation, not a conclusion. Obvious next steps are to expand and deepen this framework, and we hope the field does too. Beyond this, There is a need to develop annotation resources for additional procedure types beyond these initial 10 for comprehensive coverage across surgical specialties. We believe this work represents a pivotal moment for the surgical data science community, and we're excited to see how the community builds upon this foundation. Dr. Malambo, our global co-authors, and I encourage you to read our article for the full technical details. Thank you for your time.